Hello, sir. Hello, sir. Anyone join? Hello. 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 Ramakrishna sir. Has to join.
Good evening, Dr. Sara. Good evening, Ramakrishna ji.
Good evening. Good evening, sir. Have they joined, Dr. Sudhagar? I don't know.
Good evening, ma'am. Good evening.
Good evening. Sir,
Good evening.
Sudhagar sir has joined? I don't know. Has he joined? You are traveling, no? So I don't have his number. Can you has he joined?
Yes. I'm in the train.
No. Has
I'm
he
not in
joined, Dr.
Jan.
Sudhagar and Ramakrishna sir, have you contacted Dr. Sudhagar sir? Good evening, Bala sir.
Good evening. Good evening. Good evening. Am
Sir, I don't know,
audible?
Dr. Sudhagar.
No, he's not.
I know. There is some connection problem. He's not there.
No, he's not. He has not joined yet. He has not joined yet.
Not joined. Yeah,
Must be some connectivity issue.
there is some connectivity issue. Yeah. I don't have his number.
I have. I can call him.
Yeah, because
No, I'll call him. I have his number. I'll call him. Number is busy. It is coming.
okay.
Probably some Ramakrishna must be speaking.
He has joined. Yeah, he's joined. Yeah. Good evening, sir.
Good evening, Sudhagar.
Dr. Sudhagar sir, please unmute. Good evening. Please unmute.
Good evening, sir. Good
Yeah.
evening, madam. I was unable to join, sir.
Good evening, sir.
Good evening,
Yeah.
sir.
It was changed just now, it seems.
No, Sara was very
He
nervous.
wants-
You have not joined. That's why I tried to call you.
Yes.
Knowing you, I know you will join.
The meeting ID is changed, it seems, sir. The previous one was not opening.
Oh.
He has sent me just now. Sir, how are you, sir?
Fine.
After a long time seeing you, sir.
Yeah.
Bala Yes, sir, shall we start? You will give the introductory remarks today.
No issues. Absolutely no problem. Pleasure.
Doctor, the Zoom link has changed. The one that I've shared, 15 minutes back,
What?
that is the link, the Zoom link. So I request you to please share it with everyone.
Okay, Dr. Sudhakar, Sarah, you can give the remarks and start. Sarah, you have done so much. You please start it.
Shall I start?
Yeah, please start.
Yeah. So welcome all dear postgraduates to the next session of PG Reach. I hope you have been benefiting from these sessions and attending and learning from these sessions. Today we have another presentation on infant with jaundice. The presenter is Dr. Parasuram and the mentor is Dr. Sudhagar. He's the former professor of Kurnool Medical College and now working as a chief consultant in KIMS Kurnool. He's an excellent teacher. He's also was the ex-vice president of Central Zone. So I welcome sir and your resident to start the presentation. Is he there on board? I hope he's there.
Yeah, I'm looking for him, madam.
Parasuram has joined. Yeah.
Same problem is there for him also. Because that is the link.
He is not yet joined.
Yes,
He is not joined.
Dr. Sudhakar, please share the new link with him.
Yeah, that's what I'm saying. Parashram join galade. అదే లింక్ మాది ఒక పంచే నీకు ఇప్పుడు కొత్తది పంపిస్తున్నా ఆ లింక్ తో జాయిన్ కాదన్నా జాయిన్ ద న్యూ లింక్ ఐఎమ్ సెండింగ్ రైట్ నౌ ఓకే the link is just now changed at 8:55 p.m. they have sent the new link. Parshram got it? Okay. మన వాళ్ళందరూ కూడా other people కూడా the same share చేయండి. But they're also facing the same trouble. I don't know. All the groups were shared on the previous link only. Okay. Sir, first you join. No, the passcode is just below that. Okay. Join Ayapava? Okay. Yes, you're visible now.
Yeah.
Sir, almost all the people have got the same trouble, sir. They're calling me.
Okay, Dr. Parasuram has joined, I think. Yeah. Ask him to unmute.
Parshram?
Okay, sir.
Unmute చేసుకోండి Parshram.
Please unmute. Yeah.
Good evening, sir. Good evening.
Oh, good evening.
Yeah, good evening. Good evening. Yeah. You try your slides.
First, to project, share your slides.
Okay, sir. Okay, sir.
Click on share screen, then open your presentation, just show.
Okay, sir. Okay. Okay.
Click on the share screen,
Okay, sir. Okay, sir. Share.
exactly in the middle of the bottom. Yeah. Ah, right.
Now, where is it? You open it. Yeah. Okay. Okay.
Okay.
Yeah, it's come. Yeah.
Good. Good evening, everyone.
Yeah.
Today I'm going to present a case. Infant with neonatal jaundice. Shall I proceed, sir?
Yeah, yeah.
Yes, yes. Yes.
Good evening, ma'am. General information. I'm presenting a case of baby of Suvarna, a 60 days old, born out of non-consanguineous marriage, resident of Andhra Pradesh. Informant is mother and history seems to be reliable. The child was brought to pediatric OPD 6 days back with chief complaints of repeated episodes of yellowish discoloration of
Hold on,
eyes
please.
and skin since birth, passing clay-colored stool since birth, sir.
You complete your history taking, Pashra.
Okay,
Then
sir.
you come back point by point again later. Huh?
Okay, sir. A 60 days old male child was brought with a history of yellowish discoloration of skin and eyes since birth, intermittent, insidious in onset, progressively increasing, but the intensity decreases after exposure to sunlight, according to mother, but reappears after 5 days and associated with passing high-colored urine. The child was admitted in NICU on day 3 of life and treated for sepsis and neonatal jaundice, initially with phototherapy, later by udiliv and fat-soluble vitamins. Following with the jaundice subsided and the child was discharged with advised for further workup of jaundice. On follow-up visit 6 days back, the pediatrician noted yellowish discoloration of skin and sclera and advised hospitalization. History of present illness continued. History of passing intermittent clay-colored stools. No history of vomitings or poor feed intake or lethargy. No history of abdominal distension. No history of fever with rash. No history of increased frequency of urination. No history of constipation or delayed passage of meconium. No history of abnormal phases noticed by the mother. No history of melena or other bleeding manifestations. As per history, the baby.
No, I think, can we go back to your history? History is very short.
Okay, ma'am.
First of all, we have not understood what is this intermittent and progressively increasing. Cannot correlate both these terminologies. So was the jaundice intermittent or was it progressively increasing?
The jaundice is progressively increasing, ma'am, but after initial medication, it got subsided as per mother, ma'am.
No, why you want to use intermittent? Have you got a history that the jaundice really completely became all right and then again it reappeared? Which I doubt.
Okay.
Was this the case here?
Yes, ma'am. Yes, ma'am. It's intermittent.
Or the intensity was waxing and waning. It's not very clear from your history.
Yes, ma'am. The intensity is waxing and waning, ma'am. But the mother is saying that after exposure to sunlight, the jaundice got decreased and it reappeared after a few days.
So it did not disappear, no?
Yes, ma'am.
So I think your word that intermittent jaundice may not be correct. No, jaundice was always there, I suppose.
Yes, ma'am.
Am I right?
Yes, ma'am.
Then in the negative history, why did you ask for fever with rash?
To rule out any intrauterine infections, ma'am.
Because this baby started, icterus started from what age of birth?
From day 3
What
of
age
life.
of
ma'am.
day?
Day
Day
3 of
3.
life. ma'am.
Okay.
Yes, ma'am.
So day 3 of life, fever with rash is significant. Fever with rash.
Yes, ma'am.
Yes. Why?
To rule out any torch infections. ma'am.
So do you get fever?
Yes.
Is fever a representation of
No, ma'am.
torch? Okay. Can you go to your negative histories? Can just tell why you asked for all those histories?
Okay, ma'am.
The previous slide. Yeah. No, I think the next one.
Yes.
Yeah. Please tell us the relevance of each of these points.
Okay. No history of vomitings or poor feed intake or lethargy, ma'am.
Yeah. So vomiting, lethargy, that points to what?
Feed
What
intolerance.
were you specifically interested in? No,
Galactosemia.
just more than feed intolerance. Anything pertaining to this case, you are presenting a infant with jaundice, isn't it?
Yes, ma'am.
So what is the relevance of vomiting, poor intake, lethargy?
To rule out
Any specific conditions you are thinking in mind? Yes, to rule out
galactosemia.
what? Yes, yes, galactosemia. Yes. Then
To rule out any intrauterine infections also.
sepsis.
Sepsis, ma'am. To rule out sepsis also.
Okay. Okay.
No history
Why
of
increased frequency of urination? Yeah.
UTI also can cause jaundice, ma'am. Coincident UTIs can cause jaundice, ma'am. That's why urinary tract infections can cause neonatal jaundice also, ma'am.
But is this the history? Usually in neonatal period, you get increased frequency of urination.
Passage of foul color urine, foul smelling urine. ma'am.
Yeah. They present with fever, vomiting, like signs of sepsis, isn't it?
Yes, ma'am.
They will not present with increased frequency of urination, etc. Okay. Why constipation? What constipation?
In syndromic babies, there will be delayed passage of meconium, ma'am, and also hypothyroidism, ma'am, to rule out hypothyroidism.
Okay. What are some of the other causes for delayed passage of meconium?
In Down syndrome, if at all any syndromic
Yes.
babies due to duodenal atresia and
Okay.
GI malformations, there will be delayed
Okay.
passage of
Down syndrome, structural anomalies,
allergilism.
and hypothyroidism.
Yes,
What
ma'am.
else? Any other genetic disease? What about cystic fibrosis?
Yes, ma'am. Cystic fibrosis also there
Can
will
you have?
be. Yes, ma'am.
Yes. Okay. Chick, carry on.
No history of melena and other bleeding manifestations. The baby is suffering from chronic disease, duration 2 to 2 months, non-infective etiology. The system involved appears to be hepatobiliary, probably cholestasis. As per history, my DD or biliary atresia, genetic, progressive familial
No,
intrahepatic.
I think, Parasuram, I think, can I interpret? I think history of present illness is too short. It has not given us many things.
Yes,
You
ma'am.
have not told us the color of the stool, color of the urine. Have you told us?
Yes, ma'am.
What was the color of the urine? You
High
said the
color.
stool was intermittently pale color.
Yes, ma'am. Yes,
The
ma'am.
color of the urine,
Color of the urine is high
have you
color,
mentioned?
high color urine, ma'am.
So how will you ask? How will you elicit that history in a neonate or a infant? What question will you ask the mother?
Did the
Why is
baby
it important and how will you elicit that history?
did the baby is passing clay colored stools or not? Or
You said the stool is intermittently clay colored.
yes, ma'am.
Okay. So intermittently clay colored means what?
Actually, the baby is passing clay colored stools only, ma'am. But the superficial layers of stool may be
Maybe. So you think that is a possibility. Sometimes it's appearing yellow. So how you're supposed to see the color of the stool and how you're supposed to see the color of urine? You're saying that the outer layer of the stool can be colored because
Yes,
of what? What is the reason for that? So how should you actually examine the stool? Yeah, someone has put it on the chat box. For urine, you look at the diaper staining.
yes, ma'am. Urine diapers.
Ah,
But
and stool also actually you should press it and make it into a paste and see the inner color.
okay.
But if you just look at the outer color, as you said, it may appear to be stained. So you have to just press it and make it into a paste and just see the color, then see the color to know whether it's actually clay colored. Why is the diaper stained yellow? What is the reason for that? Which you should have mentioned.
Yes, ma'am.
And it's very important when you make that whether the stool is persistently clay colored or intermittently clay colored.
The stool is
What is the
intermittent.
difference? What is the difference in the two symptoms? Persistently clay colored and intermittently clay colored. Tell me how you analyze these two different symptoms.
Actually, the baby may be passing persistently clay color stools, ma'am.
Okay, if it is persistently clay colored, what does it indicate? And if it's intermittently clay colored, what does it indicate?
Persistently passing clay color stools indicates that there will be obstruction from gallbladder to gastrointestinal tract, ma'am.
Yes.
That
Then you are thinking of a lesion like a
obstructive
biliary
atresia,
obstructive lesion.
biliary obstruction.
Okay.
Okay.
Yes. Okay, carry on. No, your broad hypothesis is it?
Ma'am,
So what was the color of this baby's urine? Was the diaper staining yellow?
the diaper is staining yellow, ma'am. High colored stools, high colored urine, ma'am.
Okay.
Natal and postnatal history, ma'am. Antenatal period was supervised. Mother had received TT injections and had taken iron and folic acid supplementation. No history of fever with rash during gestation. Baby was born to 23-year-old primary mother at 9 months of gestation by emergency LSCS. Indication premature rupture of membranes. Baby cried immediately after birth, and the baby birth weight is 2.7 kgs. Immediate postnatal was uneventful. Breastfeeding was initiated on day 2 of life.
What antenatal history is important here?
No history of fever with rash, ma'am, to rule out any intrauterine infections like
That you said, that you mentioned. Anything else? Will you ask for any particular history relevant in this case in the mother?
Any history of rash during antenatal period, ma'am?
What?
Any history of itching during antenatal period? Ma'am?
Yes. Why do you ask that?
Intrahepatic cholestasis.
Why do you ask for that?
Intrahepatic cholestasis of pregnancy to rule out.
Of pregnancy.
Yes,
how does it affect?
It can pass on to babies, ma'am.
Okay.
Are there any prenatal scans for the mother?
Yes, sir. The scans were normal. Sir.
Scans for normal. So the newborn screening was done for the baby at the time of birth.
Yes, sir.
So
The screening
nothing-
was also normal, sir.
Mhm.
Diet history. Diet or nutritional history. The baby is exclusively breastfed, sleeps for 2 to 3 hours after feeding and passing urine and stools regularly. Developmental history. The baby attained social smile and partial head control is present, sir. Immunization history. The baby.
It's only 60 days, no?
Yes, ma'am.
So you will call already partial head control.
Yes, ma'am. The mother is saying that the baby is attaining some amount of head control while lifting.
Not really, yeah. That's not really head control at 60 days. Okay, carry on.
Immunization history. The baby received birth vaccines, BCG, OPV, hepatitis B immediately after birth. And at 6 weeks, the baby received DPT, OPV, and hepatitis B vaccination. Ma'am. The child's vaccination history is up to date. Ma'am. Family history, age of the mother, 33 years. Age of the father, 33 years. Age of the mother, 23 years. Non-consanguineous marriage. No history of abortions or stillbirth. No history of similar complaints in the family. Pedigree chart. The child is firstborn to the couple, non-consanguineous couple. Socio-economic history. Child belongs to a joint family with 7 living members, residing in a 2-room Paka house. The father is an MBA graduate working for a private company and earns 35,000 per month. Mother studied till 6th standard and is a homemaker. The house has 2 living rooms with a separate toilet and bathroom with adequate ventilation. The water supply is by corporate water pipeline. Belongs to upper middle class socio-economic class, as per Kuppaswamy's claim. General physical examination. Child is conscious and alert. Vitals. Pulse rate 134 per minute, regular in rhythm, normal volume, felt equally in all peripheral pulses, no radial or no radiofemoral delay. Respiration 38 beats per minute, abdominothoracic type. Blood pressure 82/66 mmHg in right upper limb at the time of taking history. Temperature 98.2 Fahrenheit. Interest present. The child is clinically icteric. No history of no pallor, icterus, no pallor, cyanosis, clubbing, chylonychia, edema, and lymphadenopathy.
No, please go back to your.
Okay.
How deep was the icterus? You should mention how much was the icterus. Was it?
The child is icteric till palms and soles, ma'am.
What else you will look for to see how deep the icterus is? Where else you will look for? You should also look for the mucous membrane, staining of the mucous membrane, like oral cavity. If there is staining of mucous membrane, that again indicates deep jaundice. Okay. Did you look for any abnormal facies?
Yes, ma'am, but the child doesn't have any abnormal faces, ma'am.
So why did you look for in a child with jaundice? What is the significance of looking for abnormal facies?
Abnormal faces may be seen in syndromic babies like Down syndrome, ma'am, and Alageli syndrome, like triangular faces in Alageli syndrome.
Okay. Okay, carry on.
General physical examination. Child is conscious. Head to toe examination. Anterior fontanelle flat 3/2 centimeters. No dysmorphic faces. No cataract. No ecchymosis or petechiae. No signs of vitamin deficiency. Systemic examination. Abdominal examination. Inspection. Shape of the abdomen is flat, not distended. Umbilicus central in position. No flank fullness. No sinus scar or dilated veins. No hernial orifices. No visible peristalsis. All regions moving equally with respiration. No visible lump. Palpation. All the inspector findings are confirmed. No local rise of temperature or tenderness. No guarding or rigidity. Organomegaly. Liver 4 centimeters palpable under right costal margin. Surface is smooth. Consistency soft. Moves with respiration. Tenderness is absent. Inability to insinuate finger between mass and costal margin. Percussion. While percussing, liver span is 7 centimeters. No fluid thrill or shifting dullness. Auscultation, bowel sounds heard.
What about spleen? You did not comment with the spleen. Go back to the previous slide. Was the spleen palpable?
No, ma'am.
What about spleen?
Spleen is not palpable, ma'am. Spleen is not palpable.
Not palpable.
Yes.
Okay.
Systemic examination, other systems examination, cardiovascular system, S1, S2 heard, no murmur. Respiratory system, bilateral air entry present and equal. Central nervous system, child is alert and AF is flat. Summary, a 60 days old male child born out of non-consanguineous marriage with yellowish discoloration of skin and sclera and skin with intermittently passing clay color stools has hepatomegaly, icterus and failure to thrive. On assessment, differential diagnosis, biliary atresia, genetic, in genetic progressive familial intrahepatic cholestasis, alpha-1 antitrypsin deficiency, and third one is intrauterine infections such as starch infection.
Parasuram, would you like to modify your summary? There are some other important qualifying statements are important.
Okay.
A 60-day-old is a child, well-looking child, ill child.
Well-looking child, ma'am. 60 days old, well-looking.
Well-grown. What was your anthropometry? Did the baby grow well? 2 months. What was the weight gain? Is it important or not?
Yes, ma'am. Yes, ma'am.
Was it a well-looking baby? Did the baby grow well in the last 2 months?
Yes, ma'am. As per mother,
so what was it?
As per mother, the baby is gaining weight.
No, as your interpretation.
Through anthropometric, through anthropometry, the child got a failure to thrive, ma'am. Length is.
Yeah, so this baby has not grown.
Yes, ma'am.
So this baby has not grown well. Yes or no?
Yes, ma'am.
Baby has failure to thrive.
Yes, ma'am.
Yes or no?
Yes, ma'am.
Okay. Baby has. So baby has failed. So go back to your summary. Go to the summary.
A 60 days old, well-looking male child born out of non-consanguineous marriage.
No, was the baby well-looking or ill-looking?
The baby is actually well-looking, ma'am. The baby has failure to thrive, ma'am.
Baby has failure to thrive.
Yes, ma'am.
Yes or no?
Yes, ma'am.
And there is intermittent clay-colored stools.
As per history, there is passage of
Hepatomegaly, icterus, failure to thrive. Yeah, you've written failure to thrive on clinical assessment and no history of fever.
Yes, ma'am.
So I want to know with this, will you put biliary atresia as your first? Is the order of your differential diagnosis? Would you like to rearrange or would you like to keep it the same? Any statement which is contradictory?
Yes, ma'am. I will keep intrauterine infections.
Or would you like to reorganize? What would be your thought?
I will reorganize, ma'am.
Yes. So
Genetic is my
first and foremost, when we say intermittently clay-colored, if you are expecting biliary atresia, the classic history would be the stools are persistently clay-colored. The other thing, if you have not examined the stool properly and you are thinking that the outer layer may be coated, this is after examination.
Yes, ma'am.
I suppose you must have seen the stool yourself. Have you seen the stool of this baby yourself?
Seen, ma'am. I have seen.
You have seen. So then you can verify, no?
Okay.
Was it really clay-colored? So if you're using intermittently clay-colored, biliary atresia may not be the correct thing. And also, another thing is that the baby has failure to thrive.
Yes, ma'am.
What happens to the growth in biliary atresia?
The growth.
How are these babies? Do they grow well?
They
Or
grow
do they
well,
say-
ma'am.
So these 2 points, I would say that you shouldn't put biliary atresia on top in this baby.
No,
That's why I'm asking, how would you like to reorganize this, rearrange your order?
I will rearrange, ma'am. As per the priority, genetic will be first priority, ma'am.
Which
followed-
one?
Genetic
Genetic.
will. Yes, ma'am.
But they are not even consanguineous marriage. Non-consanguineous,
Yes,
no?
ma'am. Non-consanguineous marriage.
Yeah. And so would you, I will not even put that first. Are you considering intrauterine infections?
They can be considered, ma'am. But the mother doesn't have any history of fever or rash or any.
May not be there. Mother may not have. In all intrauterine infections, you may not get a history of this thing. But
You-
the baby did not have any. Baby was not a small for gestational age baby. There was no microcephaly. Yes or no?
Yes,
Huh?
ma'am. Yes, ma'am.
Yes, there was nothing much to suggest. Still, I would put infections on top. Then the second, what other cause you have not mentioned here? You have forgotten to mention the
Sepsis, ma'am.
metabolic causes.
Symbolic.
So would you consider any metabolic cause here?
Yes, ma'am.
So first of all, from the history, I want you from the summary, your differential. Are you thinking of a hepatocellular cause or an obstructive cause?
Obstructive
So
cause.
basically, this is a neonatal cholestasis syndrome, isn't it? Differential.
Yes, ma'am.
So neonatal cholestasis syndrome, are you thinking of an obstructive cause or a hepatocellular?
Obstructive cause, ma'am.
You are thinking of obstructive, surgically correctable cause, requiring surgical cause, like biliary atresia.
Yes, ma'am.
Okay, what other medical causes you will consider?
Medical
We
cause. ma'am.
We talked about intrauterine infections.
Yes, ma'am.
You are not thinking of a sepsis here because there was no presentation like sepsis in this baby. Metabolic causes would you like to consider?
Yes, ma'am.
What are the metabolic causes you would like to consider? And do you have any points favoring metabolic cause?
Tyrosinemia.
What are the metabolic causes?
Tyrosinemia, ma'am.
Yes, yeah. One can be tyrosinemia. How do they present?
They can have.
And you already mentioned galactosemia earlier.
Galactosemia also.
So what are the features which is not there in the baby or which is there in this baby to favor or not to favor galactosemia, tyrosinemia,
Usually, E. coli sepsis will be there.
cystic fibrosis?
UTI, E. coli sepsis will
Yeah,
be there.
galactosemia may present like sepsis. Okay.
But
Usually those babies also fail to thrive. They have vomiting.
yes, ma'am.
They may have hypoglycemia. Tyrosinemia, how do they present?
They do present with the failure to thrive, ma'am.
And
Vomitings will be there. Ma'am.
what else? They usually have coagulopathy. So many times you have bleeding manifestations. This baby did not have any petechiae, ecchymosis, any bleeding diathesis from anywhere. Did this baby have? No.
No, ma'am. No, ma'am.
So little unlikely. But still you should put it in your differential. So coming to the genetic, is alpha-1 antitrypsin deficiency common in India?
Not that much common.
Not that common. Yes or no? Huh? Still, I would have considered cystic fibrosis.
Yes.
More common than alpha-1 antitrypsin.
Deficiency.
Dr. Sudhakar sir, your comments, and Bala sir, are you there?
Let Dr.
Yes, sir.
Sudhakar.
Please come.
Sudhakar, it's up to
Okay,
Sudhakar.
carry on, sir. I'm
I'll
listening.
just come in later. I'm listening to you. You're doing wonderfully. Dr. Sudhakar, please. I'll come in the end.
Yeah. Sir. Look, continue, madam. We're intently listening, madam. What are you discussing?
I'm keenly listening. I'll reserve my comments later. Yeah.
You continue, madam. Continue.
Okay, Parasuram, continue.
I would like to investigate the jail.
Yeah, 1 minute, 1 minute. Just if you are going for investigation, then I'll come in.
Okay.
Parasuram, a very nice presentation. You did a very good job.
Thank you, sir.
Now, my suggestions for improvement. After all,
Okay, sir.
we should all improve from every session that we take part.
Yes, sir.
There are a few red herrings in your history, few red herrings in your physical fighting. I'll take one by one.
Okay, sir.
In the history, you said that it is intermittent jaundice.
Yes, sir.
See two things. And then when madam asked you, you immediately said that is what the mother said. Yes or no?
Yes, sir.
Okay. Now, first of all, you must remember, never say, having said that the history is very reliable, do not say this is what the mother told me. Mother is not likely to be right. Now, I'll ask you one simple question. You have seen the case, you have taken the history, you have done the physical exam. Do you think this is intermittent jaundice or persistent jaundice?
Persistent jaundice, sir.
Oh God. Now, where is the mistake? Where is the mistake? Where did the mistake happen?
In,
Mistake is from the mother's side or from your side?
from my side only, sir.
Correct. So never put the blame on the parent, poor parents. If your history and if your physical examination suggests it is persistent jaundice, don't say as per the mother.
Okay, sir.
After all, Dr. Sara very clearly said that the stool has to be cut with a knife to see the interior. Do you think a mother will see that?
No, sir. No, sir.
So she is not likely to be right. That is number one. Okay. So it is persistent jaundice. Now I'm going to question you, if it is intermittent jaundice in a 60-day-old infant instead of persistent jaundice, the jaundice is really intermittent. What etiology would you think of? What diagnosis would you have considered? I'm trying to infuse some knowledge into you. Forget this case.
Okay,
This is
sir.
persistent jaundice. But if the same story is correct, the mother says there is intermittent jaundice, 60 days old infant, what are the conditions you would have thought of?
Cystic fibrosis, sir.
Cystic fibrosis, will it cause intermittent jaundice?
No.
Never. It will cause
Never.
persistent cholestasis and cystic fibrosis will never improve. Just like that. Hey, forget
Any
this.
abdominal mass?
In fact, if it is intermittent jaundice, you should have thought of a choledochal cyst
Yes.
or inspissated bile
Bile
syndrome
duct.
secondary to phototherapy.
Okay, sir.
Okay.
Okay, sir.
Or very rarely, madam asked about family history, benign recurrent intrahepatic cholestasis. Benign recurrent cholestasis.
Okay, sir.
Okay.
Okay, sir.
Last but not the least, the jaundice due to lack of breastfeeding may be intermittent.
Okay, sir.
Usually mother feeds well and later she does not feed well. Okay, that can cause an intermittent type of jaundice. Rarely, because not in this age group, you always think of an intermittent obstruction like a cyst or a stone, etc. They are all very, very uncommon. That is my next question.
Okay,
Now,
sir.
another question I wanted to ask you, what is the birth weight of this baby?
2.7, sir.
What is 60 days old baby, born with a birth weight of 2.7.
Okay, sir.
60 days, you as a primary pediatrician, you make out a weight of 3.7.
Yes, sir.
You call it failure to thrive?
Yes, sir.
Why? How?
Uh,
The point that you must remember is 2.7 normal birth weight.
yes, sir.
Normal.
2.8 kgs, normal birth weight.
This baby, you said 2.7, isn't it?
Yes, sir.
And if you plot the centile of this baby, you have a growth chart of this baby?
No, sir.
You plot the centile, I am very sure 2.7 to 3.7 for 60 days will very much be the same centile. So I wouldn't blame the whole thing and say that it is failure to thrive. 1 kg weight, you must remember, first 10 days it loses and gains the weight. So another 50 days, 1 kg, I mean, I wouldn't call it as failure to thrive. The same centile only. It's a baby is born IUGR 2.7 is intrauterine growth retardation. It's not a normal weight. The average weight is, if it is less than 2.8, there has been some intrauterine growth retardation if the baby had been termed.
Okay, sir.
So I wouldn't say that the baby is really failing to thrive. 1 kg, I would say no serious concern of failure to thrive. I mean, at the same time, yes, in an exclusively breastfed baby, I would have probably expected a little more than 1 kg. So I wouldn't call it as failure to thrive.
Okay.
That's another comment of mine.
Okay, sir.
And the other thing is, you said in your differential diagnosis, you said intrauterine infection.
Yes, sir.
In fact, I'll tell you with this story, I would not consider intrauterine infection at all in this baby.
Okay, sir.
I would say that's a dustbin diagnosis for the following reasons. One, there doesn't seem to be any systemic disease in this baby other than jaundice and hepatomegaly.
Yes, sir.
So that never happens in an intrauterine infection.
Yes.
And more importantly, I'm sure seniors like Sudhakar and Sara would agree, many a time is wasted by pediatricians by doing unnecessary tests like your CMV IgM and putting the blame on CMV and missing biliary atresia. It's a dustbin diagnosis. So in the absence of microcephaly, cardiac defect, dysmorphism, or hydrocephalus, or thrombocytopenia clinically, bleeding diathesis, splenohepatomegaly rather than hepatosplenomegaly, I would not consider intrauterine infection at all in this baby.
Okay, sir.
Last comment is, you said the jaundice improved on sunlight.
Yes, sir.
I strongly object to your statement. Your sunlight doesn't do anything for jaundice. I'm sure Sudhakar would agree.
Yes,
It
sir.
doesn't do anything. So don't say sunlight reduce the bilirubin level. It will never reduce the bilirubin level. Okay.
Okay, sir.
So that is it. That is it. And finally, this baby is well, clinically well, isn't it? Yes,
Yes,
or no? Except
yes,
for
sir.
jaundice.
Yes, sir.
Clinically well, not dysmorphic, only has hepatomegaly, has cholestatic jaundice, unless proven otherwise. This is likely to be biliary atresia unless proven otherwise. That is my assessment at the end of the story. And last, the pediatrician has got a duty to the patient who comes with cholestatic jaundice. It is an emergency. I'll tell you why it's an emergency. For the following reasons. One, first thing is you have to rule out or diagnose biliary atresia at the earliest to intervene as early as possible.
Yes, sir.
Second, you have to try and find out if there is some curable cause. Immediately curable cause, which includes choledochal cyst, rarely spontaneous perforation of the bile duct, sepsis, urosepsis, and even some of these intrauterine infections are curable. Syphilis can present with cholestatic jaundice. And third, is to identify disease like hypothyroidism, which can cause either unconjugated or conjugated hyperbilirubinemia. And also rule out inborn errors of metabolism, like galactosemia. And you should make a quick diagnosis within 24 hours. So clinically, I'm sure Dr. Sudhakar would agree, this is biliary atresia unless proven otherwise, if the story is correct, right? And I wouldn't think of PFIC or Alagili, but there's nothing suggesting dysmorphism. As pointed out by Sarah, this doesn't look like a baby who has got cystic fibrosis or who has got alpha antitrypsin deficiency. These are my comments. Over to Sudhakar.
Sir, I just want to ask one thing. When a student presents intermittently clay colored, should they mention, because they might be not seeing the stool properly? And when we are contemplating biliary,
if the history is correct, if it is really intermittently clay colored, it could have happened only because the bilirubin staining of the stool in the periphery.
So
mother cannot make out.
They should refrain from using that. They should be careful in mentioning that.
Yes. The other possibility is that, see, you must remember, students may well go and read old books which write what is called Landing's hypothesis. Landing, for the person who did multiple biopsies and autopsies on these infants with biliary atresia and neonatal hepatitis. And he described a term called progressive infantile and fetal cholangiopathy. And he said that both the so-called idiopathic neonatal hepatitis, which is a dustbin diagnosis today in 2023, and biliary atresia, the insult to the liver hepatobiliary system probably takes place in the antenatal period. And the outcome is different in different individuals. Some babies go on to develop idiopathic neonatal hepatitis, they may recover. Some babies go on to develop progressive cholangiopathy and they end up having biliary atresia. And there is a syndrome called vanishing bile duct syndrome, where babies who are passing yellow stools later may pass clay-colored stool with progressive cholangiopathy. After all, it's not a static process, it's a dynamic process. In fact, it is well described in literature that some cases of biliary atresia, the stools may not be echolic in the first few days or few weeks, later become completely echolic. That's another explanation. You can always say that this is still biliary atresia. And more importantly, my perception is baby is well. I'm sure. I'm sure the student would agree. Is the baby well or ill?
Yes, sir. The baby is looking well.
Very much a point against neonatal hepatitis or intra.
And in fact, he should have added that in the summary. Well looking, that he's not added in the summary.
Yes.
Okay. Right. Over to Dr. Sudhakar.
It is well said. This is a, first of all, baby is term baby, a well-looking baby, progressively increasing jaundice, and persistently clay-colored stools are there. Urine is yellow-colored. So all these things are pointing to definitely a neonatal cholestasis syndrome extending into second and third month of life. So obviously the first possibility, until proved otherwise, must be extrahepatic biliary atresia only. All rest of things probably are diagnosis of exclusions only. So it should be like this for all practical purposes. But there are certain points might be, like for example, in this child, there are no symptoms of bleeding or ecchymotic patches, etc. Many a times by the time baby crosses second month of life, when there is complete bile duct obstruction, what we see is vitamin K dependent coagulator factor deficiency leading to ecchymotic patches many a times. In this child, we are not able to see it. Of course, the sensitivity of the finding to make a diagnosis HbA is very much less. Similarly, I have also read one more somewhere, sensitivity of the finding of clay-colored stool to make a diagnosis of extrahepatic atresia is not 100%. As sir was saying, initially might be it is having less sensitivity, later on it will become high. And it can be intermittent too for unknown reasons. And the sensitivity is only still 70 to 80% only. It is not 100%. So this point also should be kept in mind. And nowhere as of now, from birth to 60 days of life, baby never had rather disinclination to take feeds, never had a sick look, never suffered from any hospitalization, never had any sickness at all. So for all practical purposes, well-looking, well-behaving baby definitely does not favor the possibility of probably metabolic disorders as well as intrauterine infections causing, say, for example, TARS hepatitis-like conditions. And it is also true, one more thing, I don't know whether Bala sir would agree or not. The intrauterine infection, probably we can categorize them into early trimester, mid trimester, and late trimester and early neonatal infections. If you categorize them like this, maybe first trimester infections, they can present with all the systemic involvement like CNS manifestations, ocular manifestations, intrauterine growth restriction leading to what shall I say, decreased length, decreased weight. All these findings might be a feature, congenital heart disease, etc. Whereas babies who are born to mother with late fetal or early neonatal infection, this is well described in High Risk Neonate by that book. I just forgot the author name. It is well described in that. A chapter itself is given. Late fetal, early neonatal infections. They too can be responsible for neonatal cholestasis syndrome secondary to TARS hepatitis picture. So even that also I think needs to be considered for discussion's sake. So TARS infection need not necessarily be true that they must always have all these features. It can be otherwise also around. And one more point, what you have told, I am not able to agree is that consistency of the liver, soft consistency is very unusual for a 60 days period of a cholestasis syndrome. Usually, as Dr. Bala sir was saying, the damage to the liver was happening since the time of before birth. It is extending to after birth. Generally, by the time we examine the child, liver changes its consistency, it becomes firm. Shall I tell you one more thing? The very fact that you are able to say that the liver is palpable 4 centimeters below costal margin, that is to say, you're able to feel the margin of the border of the organ well. That is to say, the border of the organ is able to sustain your palpation. That indicates that there is sufficient amount of fibrous in the liver to sustain your palpation. So, the very fact that it is palpable 4 centimeters below, that too non-tender, in this context, maybe you could have revised your physical finding of soft in consistency. I think based upon this might be, it could be firm in consistency also. Spleen, of course, may or may not be palpable. And you could have also added that in this child, as and now we're able to see only clay-colored stools as well as dark-colored urine and jaundice, but no history suggests any hepatocellular dysfunction. I mean, like bleeding tendencies, etc. All those things are not there. Okay. So with these things, dominantly cholestatic disease, right? With a very well functioning liver parenchyma. So probably still the clinical possibility must be biliary atresia only. But the possibility is like bile duct positive syndromes, whether we need to consider them. Is definitely a distinct possibility to be considered. Whether biliary cysts, previously we used to call it as choledochal cysts. Biliary cysts, can it be a possibility? Still it is a possibility because sometimes real choledochal cyst may not be there as you see in type 1 or type 2 choledochal cyst, biliary cyst. There can be simply ectatic dilatation of the biliary tract inside. So those varieties also might be there. What you call as cystic biliary dilatation. This is distinct from intrahepatic bile duct dilatation secondary to biliary atresia, where you'd be able to see sclerosing walls of the biliary channels. So nothing of that sort will be seen here. That still there is one of the possibility to be considered. And the PFIC, of course, it is an attractive possibility. But the 3 or 4 cases what I saw in the past was that clinically, usually they present with well-looking baby, but pruritus will be intense pruritus will be the distinct manifestation. Even a second month the baby also will be able to see some signs of babies making some movements of itching. That's what we saw in 3 to 4 babies in the past. And maybe in the investigation we'll be able to go a little bit further, how best we can differentiate biliary atresia from the other remaining differential diagnosis. Over to you, sir. Madam, Sarah, madam.
Yeah, you can continue, Parasuram, your presentation.
Okay. Investigations, ma'am. I would like to do CBC, CRP, liver function test
Why do you want to do CRP for this baby?
to rule out any infection, sepsis.
Useless test, I'll tell you. Don't mistake me for being very strong. It's a waste of money.
Yes, yes.
It's a waste of money.
Excepting the natal period, rest of time it is
So,
useless.
yeah, you see, baby doesn't have fever, 60 days old, well baby.
Yes, yes.
CRP is a dustbin test.
That's good.
I'm sure Dr. Sudhakar would agree.
Yes, sir. Yes.
Waste of money. Go by total count and differential count rather than CRP. This is not a neonatal sepsis. Okay.
Exactly. Yeah.
What is just instead of telling this way, what is the CBC in this child? Is it normal or abnormal?
It's normal only.
Yeah.
Okay.
Absolute waste of money if you do CRP. I'm sorry. I think you should stop doing CRP for such cases.
Yes.
Yes. Left you can tell. What the total serum bilirubin?
It's
You have the values or no?
I haven't kept the exact values. ma'am.
You know the values. If you know, you can say it out.
Mm.
What were the enzymes? What were the alkaline phosphatase?
The GOT, SGPT, enzyme levels are normal, ma'am.
GGT?
Gamma glutamyl transpeptase is also normal. ma'am.
Alkaline phosphatase?
Alkaline-
Alkaline phosphatase. Alkaline phosphatase normal.
It's also normal, ma'am, in the case.
I'm surprised.
Yes, yes, true, sir.
That's what.
That
Yeah,
investigation,
are you
that
having the,
investigation repeated twice, madam.
Even OTPT being normal, because we have not examined the
yeah,
child.
no, I don't know.
Findings.
Mm.
Okay, fine.
How much is SGPT, SGOT?
Around 30, 40, sir, within normal limits only, sir.
Do you have the case sheet with you right now?
I don't have right now, sir.
What is the total bilirubin, direct and indirect?
Total bilirubin 9, sir. Direct bilirubin 5. Indirect bilirubin 4, sir.
Huh?
Direct bilirubin 5, ma'am. Indirect bilirubin 4, ma'am.
How do you define direct hyperbilirubinemia, Parasuram?
More
When
than
you call it as direct
more than 20% if the TSB value is above 5, ma'am. If the direct bilirubin value is more than 20%.
That is the old
No.
definition. Old definition. Anything more than 1 milligram percent, irrespective of the total serum bilirubin value. Remember this.
Okay, sir.
irrespective of the.
That is the latest definition. You should keep that point in mind.
Okay, sir.
The 20% is taken out now.
Okay, sir.
Excepting in people where intestinal failure associated liver disease or parental nutrition associated liver disease, there the point is taken at 2 milligrams percent. Otherwise, 1 mg is sufficient.
Okay, sir.
Okay. What about GGT?
73, sir.
73. So normal.
Normal only, sir.
Normal well. In fact, in literature, it is given like this. Elevated GGT congenital cholestasis syndromes, normal GGT cholestasis syndromes, in which the normal GGT, probably three things are described in that. One is prefix, second thing is bile salt disorders, like synthetic disorders and transport disorders. These things are described in that, sir. Okay, what about PTINR?
PTINR normal, sir. One only, sir. INR is
Okay. FIDA scan?
Serum albumin,
serum albumin 3.4, sir.
forget that. Before you go further, what is your interpretation of these tests so far?
Yeah, yes, that's important. What's your interpretation of this test?
The investigations are normal only, ma'am.
Is it conjugated hyperbilirubinemia or not? First point.
It is conjugated hyperbilirubinemia only, sir.
One. Next. Is there hepatocellular dysfunction?
No, sir.
Enzymes are normal.
Enzymes are normal only.
Normal enzymes, normal albumin, normal PT, and alkaline phosphatase is normal, GGT is normal, OTPT is normal, conjugated hyperbilirubinemia is there. What's your diagnosis? Forget, I don't know the diagnosis. I have not seen the patient. I'm asking you. What's your diagnosis?
Bile acid synthesis defects or transporter defects.
Transport defect. Any other diagnosis? Any other benign disorder? Benign disorder.
Any hereditary congenital?
Yes, madam is giving a clue. If it is unconjugated, you always think of two disorders. If it is conjugated, hereditary, you think of two disorders.
Crigler-Najjar or Gilbert syndrome.
That is for unconjugated.
For conjugated, Dubin-Johnson or Rotor syndrome.
In fact,
Dubin-Johnson and Rotor.
yeah. Of course, the only point is, I don't know, there is something wrong somewhere. I don't think you can have cholestatic jaundice of such significance to the extent of passing clay-colored stool with normal alkaline phosphatase. I'm sure Sudhakar and
Yeah, yes.
something wrong.
Yes, definitely, sir. Yeah.
Yes, this test is repeated in other lab also. It has come to be same.
No. I would look at the stool myself.
Yes.
Okay. But you can't have GGT, okay. You can have in so many other disorders a bile acid metabolism. But alkaline phosphatase is not.
What is the absolute value of alkaline phosphatase?
I couldn't recall, sir, but it is in normal limits only, sir.
I'm surprised.
You could have written.
See, that's a basic abnormality you get when there is obstruction. Cholestasis, whether it is intrahepatic or biliary. Wherever the problem, the alkaline phosphatase has to go up.
Yeah, that's very surprising, sir. Something not fitting.
To me, it doesn't fit in. It's okay, fine.
Okay.
What with the ultrasound? I'm sure before going to the HIDA scan and torch and genetic and all, you would have done an ultrasound.
Yes, ma'am. Ultrasound is suggestive of hepatomegaly.
What else are you interested in seeing in the ultrasound?
Triangular cords in
No, before that.
Gallbladder, how is it?
Maybe gallbladder, triangular cord, everyone may not pick up that sign. Did you look for the gallbladder?
Yes, ma'am. Go.
So how was the gallbladder?
Gallbladder.
What, visible, not visible, then post feed, anything?
Visible, ma'am. Gallbladder is visible.
Was normal, huh?
Is it a pre-feed or post-feed?
Post-feed, sir.
Huh?
Would have emptied.
It was a pre-feed ultrasound.
Sir, fasting ultrasound.
Okay. Today has become father,
Okay.
madam. Today, Dr. Parshram has become father for the first time.
Yeah, okay. Oh, congrats, yeah.
Just few hours back.
Oh, good news. Yeah,
Rampant.
Parasuram, continue.
Hidascan, ma'am. Hidascan done also. It came out normal, ma'am.
So why did you do? What is the indication for doing HIDA scan? When do you do HIDA scan?
Yes, I was going to ask you that. What is that?
I have not done a HIDA scan for the last maybe 10 years.
Okay, sir. It usually pick up biliary atresia, sir. After 3 to 5 days of priming with phenobarb, we will do, sir.
Actually, two things you must remember, Dr. Parasuram.
Okay, sir.
Today in 2023, HIDA scan is a waste. It's not required at all to diagnose biliary atresia. A more cheap test will be to look at the stool every day, diaper every day, rather than give phenobarbital, wait for 5 days, he's not going to give you an anatomical diagnosis. It will only delay the surgeon's time. Remember, you should operate at 2 months before 60 days if you want good prognosis. So most of the time, these parents will end up in 60 days or 40 days. Wasting your time in HIDA scan is counterproductive, and it is never going to give you anatomical diagnosis. Good ultrasonography is good enough rather than do HIDA scan at all.
Okay, sir.
Always, most centers, they don't waste time in doing HIDA scan. That's some message I wanted to convey.
Yes, it is also mentioned that HIDA scan has got, though it is sensitivity is 99%, specificity is only just 70%.
Yes.
That is the important part.
And whatever you can see clinically only, you are going to make out in HIDA scan. That's all. Right.
I would like to do torch profile and genetic testing, sir. These tests are not done.
So you are not leaving the torch profile. You're going ahead with the torch
After
profile.
I will not waste
Discussion.
my money.
And
You
it
did
will
mention
become
all the-
I'll tell you.
how to interpret.
In this child, I will do
After, okay, sir.
I will do a hearing test. I'll ask the ophthalmologist if both
Okay, sir.
ears and eyes are normal. I would not do any test because counts are normal. Nothing, spleen is not palpable. No systemic manifestation. And doing these wasteful tests of antibody, for example, CMV, IgM is a waste. Doesn't tell you anything. So I don't think you should perform touch to profile at all.
Okay,
If you suspect intra-arterial infection, the one which is often missed and it is immediately curable is,
cytomegaly.
you tell me which disease, which is curable, immediately curable, within 2 weeks.
Cytomegalovirus.
No,
Herpes simplex
Herpes.
syphilis,
syphilis.
EDRL, if it has not been, that's not being done nowadays routinely. You should do VDRL at the most because it's curable. You give penicillin, you save the life of the child, completely normal life. Everything will vanish, including jaundice.
Okay, sir.
Okay, and CMV IgM is a waste. You should do only CMV urine PCR as a specific test. Only for rubella and toxoplasma, antibody test would be of use.
Okay, sir.
And herpes simplex, we have stopped doing IgM antibodies. We go only by PCR.
This year.
So these are the important points you must remember. You should do HSV PCR if you think it is a herpes simplex hepatitis. You do urine PCR for CMV if you think it is CMV infection.
Okay,
And
sir.
you do toxoplasma and rubella antibodies.
Okay, sir.
Okay. Even for those two diseases also nowadays PCR is coming up in a big way. And we do VDR.
Okay, sir.
Yes. What genetic test was asked?
Whole exome sequencing. ma'am.
Sequencing. Yes. So what did that show?
We didn't done it right now. ma'am. We are about to send that. ma'am.
Again, Dr. Parasuram, in this baby,
Okay.
who I don't know, I didn't hear anything about your renal function. If renal function is normal, glucose levels are normal, urinalysis is normal, no acidosis, I wouldn't again waste my money on metabolic screening with a tandem mass spectroscopy. It's a waste of money.
It's true.
Okay, sir.
Not a sick baby, no acidosis, nothing to point towards any metabolic disorder. I wouldn't be doing. The only urine test I will do is a urine glucose for galactosemia, galactose. Smallish test I will do. That's all.
Okay.
So with all these things coming negative, what are you thinking of?
Madam,
The conjugated hyperbilirubinemia.
yes, ma'am. Maybe transporter defects, bile acid synthesis defects, and bile salt transporter defects, and
Possibility.
progressive familial intrahepatic cholestasis.
Was there anything to suggest pruritus in this baby?
Nothing, ma'am.
How this 2 months baby can present? How do you identify? Because they won't itch. No, the time has not come. It's just 2 months.
Yes,
So
they will
what
be
would be the sign?
irritable, ma'am. They will be-
Yes, irritability, the crying, rubbing there. Was there anything of that kind in this baby?
No, ma'am, nothing.
Baby is comfortable with.
I think one clue you can get from all these investigations is that
Sir.
this looks like a non-obstructive cholestatic jaundice.
Okay, sir.
So Bala sir, can we go back to the first thing? That's why from the history what he said. Two
Yeah.
things were, if you take it in that way, he said the jaundice was intermittent. I don't know what he was meaning. It was never intermittent, but waxing and waning. In biliary atresia, the jaundice is usually relentlessly progressive. It won't have that waxing and waning in biliary atresia, if I'm correct. Bala sir, correct me. In obstructive jaundice, it will not be waxing and waning. Here, the symptom was that it was waxing and waning. And then about the stool color also, he wasn't very sure.
Yeah.
So these two things he should have confirmed. That's why right in the beginning, I was asking, is it hepatocellular or is it obstructive? And I wasn't not fully convinced, although I understood 60 days, that's the first diagnosis you need to exclude. And the baby was not really having any pointers towards a infection or a metabolic cause. But these two things were a little bit on my mind to put my bet 100% on biliary atresia, if you ask me my opinion.
Yeah. Two things. A bilirubin level of only 8, normal alkaline phosphatase level, normal OTPT. I mean, in this baby, pruritus itself is not likely to occur. See, that means the cholestasis is not very severe. The problem is somewhere with the metabolism of the bile rather than
a little bit milder. Yeah.
Structure. That gives a distinct clue that it may be more to do with metabolism of the
Bile acids.
so bile acids rather than the obstruction, mechanical obstruction. That might well explain, if the history is correct, some intermittent jaundice. Otherwise, it's very difficult to think of. Okay.
Dr. Sudhakar sir, your comments.
Yes, sir. This baby is in our unit only, madam. We are actually following. We are really not convinced that this is a case of extrahepatic biliary atresia after all these things now. So whether it could be some bile acid synthetic disorders or transporter problems, or still it could be PF cause, we do not know. So really we want to know by doing probably further investigations. Because the baby is doing well, it is also our plan that to wait for 1 more month. Just let us wait.
Yes. I suppose in this child you can afford to wait.
Yes, that's what we are planning now. Today, actually, the child is being sent home to come back again after 1 month, madam. We are making a track of this baby. If this is worsening, values are increasing, maybe I think we can go for exome sequencing.
So do you have any previous bilirubins of this child? Maybe, sorry, earlier bilirubins. Now the baby is at 60 days old. Do we have any earlier bilirubins of this baby?
No, madam.
No.
In fact, baby lost completely touch with any physician after 7 days or 10 days of life. Now at 60 days they have come. No visits were there in between. Even while giving vaccinations also, probably this was not made out.
So that I think the intensity of jaundice, as Bala sir said, that goes against biliary atresia. By
Yes, yes,
2 months, 60 days, biliary atresia, icterus would have been really, it's only 9. The total bilirubin is just 9.
Could have been much more.
So,
You
yeah,
cannot
much
have
more.
normal alkaline stress. You cannot have normal alkaline
Yeah.
stress.
So, sir, that's what I, yes, exactly. So in the general examination also, he should have said the intensity of jaundice. He just said icteric, how
The
much
number
was the jaundice? We were not getting a clue from the, we're not getting the correct picture from the his finding. Like,
But one thing is to alkaline
Bala sir,
phosphorus
your comments.
can be normal in
Yeah,
this
alkaline phosphate is there.
bowel cell
Yeah.
disorders and PFIC also. Except in some
So
varieties.
my question is that, this baby, maybe we could have waited, no, once all this test before, without going into, HIDA scan and all the other investigations. Once the LFT is normal and the ultrasound did not show, showed a normal gallbladder. There was no choledochal cyst. We could have probably waited for this baby. There was nothing urgent to investigate this baby further immediately.
Yes, yes.
Yes.
Great.
Bala sir, your comments?
No, nothing. I told you, I've not done HIDA scan, and I would have done HIDA scan for this baby. I don't
Yes,
say.
I know. No, in this baby, all the more, sir. I'm just saying. I know HIDA
I
scan is not for ruling out; it is for ruling in. If it is completely excreted, you can say it cannot otherwise. Yeah.
Definitely, I would have asked an
So for the,
ophthalmology opinion.
yes, definitely.
Meaning
Yes, ophthalmologist for your
completion of workup. And of course, ultrasonologist will really, a good ultrasonologist will rule out biliary atresia. They will
Yeah,
look
yeah.
at gallbladder, it's
Our
contracting.
sonologist confidently told that it is not biliary atresia.
Then that's all. I don't think in such a case, I think your decision to wait is absolutely right, Dr. Sudhakar.
Yes,
We
yes.
can wait and follow up this baby.
Yeah, true, sir.
In fact, nothing is happening. Liver cell synthetic function is holding on. Honey, prothrombin time is normal,
Immediate.
albumin is normal.
Normal. Yes.
What are you going to do?
So
In
that's the
fact,
reason why we can wait, I think.
yeah, in fact, even Woodka is not going to help in this baby if it is going to be a hereditary disorder. Woodka, of course, is a harmless drug. No harm. I don't think a child requires cholesterol and other aggressive measures.
No, sir. We are not really planning for that also.
Yeah.
The baby actually asymptomatic otherwise.
Mm. Okay, sir. So I think for the postgraduates, it's very important to take a extremely good history and a meticulous physical examination, and we should be able to do a proper analysis. So I think little bit more detail in history, maybe, like we all, we would have got we would have been able to interpret or analyze this case better if we had gone a little bit in depth into the history. So I think postgraduates, that's the message. Do not be just one track mind. You should be able to think of all the possibilities, and you should be able to get the correct clinical picture. If the clinical picture, what we get is wrong, our interpretations are going to be wrong. The investigations we order may not be appropriate. So everything is based on how good we take a good history and make a good conclusion from your physical examination. So, Dr. Sudhakar, sir, anything you want to say? Tell the
No, nothing.
postgraduates. Okay.
Any questions?
There is
there?
nothing.
Chat.
Is there anything in the chat box? I don't think.
I don't think so.
Yeah, there is some. No, I think it's okay. If there is no questions, shall we close the meeting?
Yes, madam.
Yeah, we'll close the meeting. Okay.
Well done, Dr. Sudhakar.
Yeah.
Well done, our young
Yeah,
man.
yeah. It was, yeah.
Father.
Yeah, well done, Parasuram. Yeah.
Thank you, ma'am. Thank you. Thank you.
Your baby.
It was surprise. Surprises are always there. Surprises are always there. That is good. You kept the suspense. So that is good.
Presented only for this purpose, madam, because we are unable to get at a conclusion.
Yeah.
At the end of
Yeah.
True.
Yes. Right. Always better to put the investigation, the figures, not the values. I mean,
Next time.
should have put the values for us to see.
Thank you.
Thank you.
Okay. Thank you. Good night.
Thank you, madam. Thank you, sir.
Thank you. Thank you.
Thank you.